Friends, welcome back to my new video in my channel. And today I will present the last part 5 of my short video in the series of ACS, and following which we will discuss upon arrhythmias as a new series. So this is a last video as far as the ACS is concerned. Let us talk about the oral anticoagulating agents. So the trials Atlas ACS2 TIMI 51, and here they actually studied the rivaroxaban plus double antiplatelet agents. And as you could see that with this combination, of course, the death, the MI and the stroke incidence came down by about 19%. The cardiovascular death, as you could see that it came down, along with the major bleeding, which was high, which is probably very easy to understand. The stent thrombosis rate was also significantly low, and of course, the mortality was low. But let us see what are the downside of this particular therapy. So, as we know that these are the classical glycoprotein 2B3A inhibitors, namely the abciximab, the iptifibatide, and tirofiban, which is the most famous. And usual duration of these agents ranges from about 12 hours to 24 hours. And as I was talking to you about the downside of this combination, so there is of course increase in the risk of bleeding with the triple combination, where you have aspirin with P2Y12 inhibitors and anticoagulation. Of course, the bleeding rate goes up, but as you could see that what about the various dosage of aspirin, say in the form of 160 milligrams and low dose of say about 80 milligrams? And as you could see, there was in terms of outcomes, there was no difference. Of course, there was a little high bleeding with 160 milligrams of aspirin. As far as the ischemia was concerned, there was no difference, and this was the famous WOEST trial, which looked upon the triple therapy with clopidogrel and anticoagulation, where you could see that the bleeding rate was much higher in the triple therapy. So it is not very difficult to understand and comprehend that the moment you add one more drug, it will actually have an impact and bearing on the bleeding propensity for that particular combination. Now, what are the complications of ACS? Classically, it could be arrhythmic complications, the mechanical complications, pump failures, right ventricular infarctions, left ventricular aneurysm, left ventricular pseudoaneurysms, pericardial complications, complications involving bleeding, and of course, complications related to the PCIs. As far as the invasive management is concerned, and that is what we have learned so far, with the help of the current evidence, that the primary PCI, which will actually take care of the reinfarction, and of course, we need to be very cautious about the bleeding. So, with a very high risk of STEMI, we need to contemplate primary PCI within 2 hours. With a high risk, we can still, and we are talking about non-STEMI here. So, very high risk non-STEMI within 2 hours, very high, the high risk non-STEMI within 24 hours, and of course, when it comes to STEMI, it has to be between 60 to 90 minutes. So this is a very important kind of a message I want to convey that if you have a STEMI, this is a window period of 60 to 90 minutes as a door to balloon time. Uh, as far as the bleeding complications are concerned, we have already discussed, and we will discuss a bit in the next slides. So this is about the difference between the bare metal stent and the drug-eluting stent. So this is everolimus stent, which is the most favorable. There are sirolimus stents, and of course the everolimus stents, where the major cardiac events and the cardiovascular events are actually less with everolimus stent. So this is the drug-eluting stent, which is extensively preferred. As far as the thrombus aspiration is concerned, and talking about the MACE or the major adverse cardiac events and the mortality is concerned, of course, you can have the comparison between the aspiration thrombectomy versus primary PCI, where you could clearly see that there is decrease in the myocardial damage with the use of infliximab. It will also help to prevent the reperfusion injury, and exenatide, which has impact on these particular side effects, especially when used within 15 minutes. It will decrease the size of an MI, and it will increase the salvageable myocardial muscle. So this is what we can actually take away from this particular slide. And of course, with the intracoronary injection of drugs like adenosine, diltiazem, and verapamil were also tried in various other studies. Talking about the supportive management in the form of IABP, where now it is very clear based on the IABP shock 2 trial that there is no reduction in the mortality or heart failure or reinfarction rate, and even the 30-day mortality does not change. As far as the access of this is concerned in the form of either a radial artery or a femoral artery, as you could see, there is hardly any difference. So, the take home message here is IBP, as far as the present and the recent scientific evidence is concerned, still has not a significant place as far as decrease in the mortality or the complication rate is concerned. Having said that, in a clinical practice, we definitely encounter a situation where usage of IBP have helped the patient more often than not, and of course, it can be considered as one of the important treatment bridge treatment for the patients waiting for heart transplant. Now, as far as the lipids and the quality of care is concerned, these are like golden rules. Aspirin administration, which is so very vital on arrival, and of course, at discharge, smoking needs to be cesated. Beta blocker prescription has to be on discharge. ACE inhibitors for the patients with LV ejection fraction of less than 40%. Statins prescription on discharge. Referral to the cardiac rehabilitation is very important, and door to balloon time of less than 90 minutes for the patients undergoing primary PCI for STEMI. So this is an important message, along with the non-statin agent like ezetimibe for the as a non-statin agent, and of course contemplation of monoclonal antibodies in very few situations with these agents. So I think these are probably the very important points which anyone should discuss as far as ACS is concerned. So uh, just a very small kind of a quiz again, and it is a little favorite part of mine, as to throw a very simple and logistic questions to you. So, as far as STEMI is concerned, what could be the modality, what we should think of? Having understood the subject in the last 4 or 5 presentations. So, for me, STEMI will be PCI and the lysis. Non-STEMI or unstable angina, of course, the anticoagulation in the form of GP2B3A inhibitors. Cardiogenic shock, as we know, PCI is the mainstay. IABP may or may not have a role. And remember, when it is RV infarction, nitrates are a big no because it will cause hypotension. As far as the antithrombotic therapy is concerned, the unfractionated heparin and these are the dosage say schedule, the bivalirudins in a few cases, enoxaparin, of course, as a standard 30 milligrams IV bolus and then 1 milligram per kg subcut every 12 hours, and of course, fondaparinux. So, this is a table which will give a snapshot of the antithrombotic therapy. And I would end this video by my take home messages that for ACS practice guidelines, as you could see, that the PCI, which should be instituted as soon as possible, and the door to balloon time, as far as the STEMI is concerned, has to be 90 minutes, and if it is non-STEMI, it could be somewhere between 120 minutes. The the double antiplatelet therapy, and if at all we need to institute triple therapy, which will be not more than 12 months. As far as the pathogenesis is concerned, it could be non-obstructive or obstructive, and we have discussed that in detail. The standard risk factors, the OC pills, NSAIDs, patients with psoriasis, and of course the early detection would have that safety margin. There has to be an emphasis on cardiac rehabilitation as a quality indicator for the patients of ACS. We saw biomarkers, the high specific or the high sensitive troponins, copeptins, PAPPA, MAC, IL-17 and pentraxin. The drug-eluting stent, which is superior to bare metal stent. There's a questionable role of colchicine, and of course the antiplatelet therapy like ticagrelor, prasugrel, which is superior to clopidogrel, and the dosage schedule which we have actually seen. IBP is de-emphasized in the recent trials, but however, practically we find it useful. And of course, it was complicated by the deadly COVID-19 pandemic in the form of superadded inflammation and the thrombotic conditions, which were so very dangerous. So, friends, I am sure you would have enjoyed all these lecture series of 5 short videos on acute coronary syndrome. And that's all for now. Take care. Bye bye.